In order to keep the schedule on time, I think Felix will introduce the speakers of the first session. I would like to introduce Felix myself. It's a great pleasure to have been working with him for more than 7 years now. Felix, he joined us after a successful career in St. George's Hospital. It's an absolute pleasure to have him with us. Felix, thank you very much.
Thank you very much, Vasilis. And thank you for describing me as looking very young. Actually, in fact, I found a setting on Zoom to make me look even younger. You can get this. So can you see the effect? It takes away all the superficial blemishes, at least. Thank you so much. Good morning, everyone. Welcome to the Royal Brompton Hospital Sarcoidosis Patient Day. Dr. Kronos and Sarcoidosis UK have curated an excellent day for you, and there will be 6 sessions. I'm chairing the first session, which is entitled Sarcoidosis as an Entity. The 2 speakers will cover, hopefully, 2 fundamentally important areas of sarcoidosis, mainly in relation to causality or etiology or cause. That'll be Dr. Simon Hart's talk. And the second talk is Dr. Mohunthan Thillai, who will touch on diagnosis with some light shed on biopsy. Let me introduce them. The format will be, we'll have both speakers in succession, and then we'll do the questions at the end, if that's okay. Dr. Simon Hart is a very experienced physician. He's the lead clinician in the interstitial lung disease service in Hull. Simon has been involved in research and clinical practice for a long time. He has research interests covering both laboratory and clinical research in sarcoidosis. He's a co-author on the BTS clinical statement on pulmonary sarcoidosis that was published recently. And the title of his talk is Causes of Sarcoidosis, What We Know and What We Don't Know. He'll be followed by Dr. Mohunthan Thillai, who is the lead of the clinical interstitial lung disease service in Cambridge, which is a very large service and a regionally very important service. Mohunthan's specific interest is in sarcoidosis. He's actively involved in research and clinical practice. He too is a co-author on the recent BTS statement on pulmonary sarcoidosis. And Mohunthan's talk is entitled Diagnostic Guidelines in Sarcoidosis, Is Biopsy Necessary? So that's the introduction. We'll do the questions at the end. I'm hoping to do, for Simon to take 2 or 3 questions. We've gone through the questions, grouped them together by connection, by relevance and common themes. So he'll do 2 or 3 questions, Mohunthan do 2 or 3 questions. But what we're going to do is take 1 from Simon, then 1 to Mohunthan, and vice versa. We'll do them in sequence that way. So Simon, if you are ready, off you go.
Thank you very much, Felix, and thank you also to Vasilis and Leo for inviting me to speak at this fantastic event. So, the cause of sarcoidosis, what we know and what we don't. Well, we don't know the cause of sarcoidosis, and in that respect, we're not too different from Louis Siltzbach, an American pathologist who did a lot of sarcoidosis research in the middle of the last century. And this was a quotation from him 70 years ago. What has changed is that we understand quite a lot more about the biology, and I'm going to show you some of that evidence today. Why is it important to know the cause of sarcoidosis? Whilst many people with sarcoidosis get better with no treatment, many have persistent or progressive disease that causes a problem, as we've heard about from some of the patient stories this morning. And if we're going to develop better treatments, and if we're going to achieve the charity's ultimate aim of finding a cure, we're going to need to identify the cause. So in terms of thinking about that, let's focus down at the microscopic level and think about what's going on under the microscope in these abnormal areas in people with sarcoidosis. So in a person who has a biopsy, we would find abnormal areas like this, and this bit of lymph node is largely replaced with these round collections of cells that are called granulomas, and this is very characteristic of sarcoidosis pathology. And each one of these granulomas about the width of a couple of human hairs. So about
Simon, sorry to interrupt you. We don't have your screen.
Okay, I'm sorry about that. It looks like I'm sharing my screen, but let me just see. Maybe I didn't click the final share button.
Perfect.
Technical hitch at the beginning. This is the granuloma. These are collections of granulomas outlined in yellow here. And these are each the width of a couple of human hairs. And these are the characteristic findings in sarcoidosis. What are these granulomas made up of? If we look a little bit more closely, what cells are there? These cells are mainly called macrophages, and they're stained brown in this particular stain. So these are the dominant cells within the sarcoidosis granuloma. So let's think a little bit more about macrophages, what they are and where they come from. The macrophage, the word comes from the Greek, meaning large eater or large eating cell. And these cells are designed to eat and digest bacteria and other foreign particles. The macrophages themselves derive from circulating white blood cells called monocytes in the blood, which are themselves produced in the factory in the bone marrow. So when we're thinking about what causes the characteristic granuloma in sarcoidosis, it's worth thinking about what else do we know causes granulomas like this? Well, tuberculosis does, a disease that affects about 1/3 of the world's population. And so when we're thinking about how a granuloma forms, most of what we know comes from studies of TB, and we think the same processes occur in sarcoidosis. My own hospital, like many, used to be a TB hospital where patients were given fresh air treatment before the development of TB treatments. So let's use TB as an example of what happens when a granuloma forms. First thing that happens is that a person inhales the TB bacteria into their lungs. In the lungs, these bacteria are recognized and eaten by a patrolling macrophage. That's what the macrophage does. The macrophage finds that these bacteria are difficult to digest, so it realizes it's going to need some help here. So it sends out chemical signals that bring in more cells from the bloodstream, including these monocytes, which are going to later turn into more macrophages. At the same time, parts of the TB bacteria are shown to other immune cells called lymphocytes, which react by proliferating and dividing, and they're going to provide immune memory. They're going to remember this bug if the person sees it again, and we'll come back to that concept a little bit later. What happens then is that the monocytes turn into macrophages, more cells are brought in due to more chemical signals, the process continues, and you can see what's happening here. We're ending up with a collection of cells dominated by these macrophages in this round cluster, which is the granuloma that we see in TB and in sarcoidosis. Now, why don't these cells go on their way, go back to where they came from, die off, and the whole thing disappear? Well, they don't, because they release chemical signals that act on neighboring cells to maintain the cells in states of heightened activation and maintain the granuloma. One of these chemicals is called TNF, and we have drugs that can block TNF, and steroid treatment works partly by blocking these chemical signals. Now, in TB, we need a granuloma. The granuloma has a purpose to contain the TB infection and prevent it from spreading around the body. But in sarcoidosis, we can't find any TB bacteria. So what we want is that granuloma to slowly resolve, the cells to go on their way, and for it to go away. So thinking about the similarities between TB and sarcoidosis, Siltzbach again in the 1950s proposed that there were two concepts about the cause of sarcoidosis, that it is not tuberculosis because we can't find any of the bacteria, or that it is in fact a form of tuberculosis where for some reason we can't find the bugs. So that really brings us on to the first theory of sarcoidosis, that is that sarcoidosis is caused by an infection, maybe like TB, or if not infection, some other particle that stimulates an immune response. Why might we think that this is a reasonable theory? Well, if we just look at the parts of the body that are affected most commonly by sarcoidosis, they're parts of the body that are exposed to the environment, the eyes, the skin, the lungs, and so may be exposed potentially to infection. More evidence for infection comes from a historical skin test for sarcoidosis called the Gavine test, where patients with suspected sarcoidosis were injected with a mashed up preparation of a spleen from another person with sarcoidosis that may contain some infective material. And a few weeks later, if the person has sarcoidosis, when injected into the skin, this material leads to the development of these granulomas that appear as a lump, which can be proven then on biopsy of that lump. This suggests there may be immune memory in people with sarcoidosis against some sort of infectious agent, again taking us back to this concept where bits of bugs are shown to cells of the immune system. And this is also relevant to studies of genetics of sarcoidosis. So the gene sequence in the DNA sequence that encodes our genes varies between each of us, and genome-wide association studies can look at how variations in genes are linked to disease risk. And a number of genes have been linked to sarcoidosis risk. And it doesn't matter what the names are, except that many of these genes are involved in this process of showing pieces of infection to other immune cells and generating immune memory. So that suggests an infective cause. So what might that infection be? Could it be TB, another bacteria, a virus, a fungus, some other sort of particle? All of these have been proposed. There are scientific papers supporting all of these, but also scientific papers refuting all of these. So overall, the evidence for a particular infection causing sarcoidosis is currently inconclusive. If microbiology can't give us the key, what about asking people with sarcoidosis what they're exposed to in part of their life, leisure, work, and compare that with what people without sarcoidosis may be exposed to and see if we can identify what it is that causes sarcoidosis. This study has been done, and I've just picked a few of the headline results here. And the column on the right, the odds ratio, is how much more likely these exposures are in people with sarcoidosis compared with healthy people. So any number above 1 is more likely in people with sarcoidosis. But these are weak risk factors, 1.5 times, a bit more likely. That's not very strong. And so the overall conclusion from these studies are that the risk factors identified are weak, but no specific cause could be identified. So I've shown you some evidence for and against an infective theory for sarcoidosis. Could there be another theory? Well, I'm going to propose some evidence to you for an alternative theory, which is that the cause of sarcoidosis is because these macrophage cells are overexcitable and tend to form granulomas in response to things that we're all exposed to as part of our normal life and work. This is not a new theory. In fact, an early variant of this theory was proposed in the 1960s, this time by a Dutch dermatologist called Kuj, and he called it terrain sarcoidique, which I don't really know what that means, but I thought it had a nice ring to it. What about an example? People with tattoos who are affected by sarcoidosis in their skin often find that the sarcoidosis granulomas prefer the tattooed areas of skin, suggesting that the cells there are reacting to the tattoo ink. These pictures were taken by a patient of mine who kindly consented to me sharing them with you. And these are little nodules or collections of granulomas in his tattooed skin. What other stimulants might induce an over-exaggerated response? This is a fascinating paper from Germany, just published this year, looking at how changes in sarcoidosis diagnoses in blue here were related to changes in air pollution in red and yellow, and suggesting that there was a time difference of a lag of a couple of months between changes in air pollution mirrored by changes in sarcoidosis diagnosis. Maybe air pollution may be a stimulant in some people. If we think the cells are overactive, can we prove that in the laboratory? We can take those blood monocytes, the precursors of the macrophages, and this is some work from our laboratory where we simply stimulated these cells in the laboratory with an extract from uncooked red kidney beans, so a general stimulant of immune cells, and found that the patients with sarcoidosis had blood monocytes that reacted more strongly in terms of releasing these chemicals that maintain the granuloma that we saw earlier. So they do seem to be hyperreactive. Here's a nice study from Ohio, where they took the monocytes from people with sarcoidosis and stimulated them with undigestible plastic beads, and found that the monocytes from people with sarcoidosis formed clumps in the dish in the laboratory, shown here, a bit like a granuloma. And my final piece of evidence that I'm going to show you is this fantastic work from Vienna, where they developed genetically modified laboratory mice, where the macrophages in particular were overactive. And they did that by manipulating a chemical pathway inside the cells called mTOR. And these are laboratory mice, so they're not exposed to infection. They have a very clean environment, and all by themselves, these mice developed granulomas in the lungs and in the skin, very similar to sarcoidosis, suggesting that if you have overexcitable macrophages, you can develop granulomas like sarcoidosis. So I've presented to you some evidence for and against two theories. And on further scrutiny, some of the bits of evidence I've shown you can actually be interpreted either way in favor of either theory. And it may be that the truth is that there's a bit of both, that in order to get sarcoidosis, people need for some reason to have overexcitable monocytes and macrophages, and potentially then be exposed to a stimulus to trigger the formation of granulomas. So whilst we don't know the cause of sarcoidosis, similar to 70 years ago, we do understand more about the biology. But what you can see is that there's a lot more research to be done. And that's why the work of Sarcoidosis UK in terms of funding research with funding from its fantastic fundraisers and those of other sarcoidosis charities internationally, that's going to be absolutely vital going forward. Thank you very much.
Thank you very much, Simon. That was excellent. We're going to go to Muhanthan. Muhanthan, it's over to you.
Thank you very much, Felix. I'm just going to try and share my screen. So please tell me if you can't see this, but I'm assuming that everybody can see this. And can you see the slides, Felix, okay?
Absolutely.
Great. Okay, so hopefully there isn't too much of the other stuff on there. So thanks a lot, Felix, and thanks, Simon, for a great talk. Thank you to Leo and Sarcoidosis UK, and also Vasilis and all his colleagues at the Brompton for putting on such a fantastic day. It's really exciting to talk to you all about sarcoidosis. So I'm going to talk about biopsies. I'm based in Cambridge at the Royal Papworth Hospital, and we've been thinking a lot in the last few years about biopsying different parts of the body and biopsying the lung for sarcoidosis. And there has been a relatively radical shift in our thinking for biopsy. In simple terms, 20 or 30 years ago, doctors and nurses wanted to biopsy all parts of the body, especially the lungs, to try and diagnose sarcoidosis. We're a little bit more conservative now, primarily because CT scans and the ways we look at images of the lungs are so much better that we don't always biopsy the lung when we have a confident diagnosis. And I'll explain that to you. So you saw this picture earlier from Simon. This is from a recent publication, and this shows you that sarcoidosis around the world can affect almost any part of the body, the liver, the bone marrow, the kidneys, the spleen, but it predominantly affects the lungs. In between 70 and 90% of cases, the lungs are affected. And if other parts of the body are affected, like the heart or the eyes, often the lungs are also affected. So most of sarcoidosis, especially in the UK, is looked after by lung doctors and nurses, but we have to have an understanding of different parts of the body, especially when we want to think about biopsy. And so why do we biopsy? For something like this? This is a CT scan, and so some of you as patients will have seen your own CTs, but if you haven't, imagine this as a very detailed X-ray, and this is a slice through somebody's chest. The very big blob in the middle is the heart, and the two larger black areas are the lungs, and there's an arrow there pointing to a lymph node. And in this person, the lymph node is a lot bigger than it should be. And the problem with this sort of picture when you see a patient is that this could represent one of a million things. It could be sarcoidosis, it could be cancer of the lung, it could be cancer spread from somewhere else, it could be an infection, it could be anything. And interestingly, in this patient, it turned out not to be sarcoidosis, but a fungal infection. And so often when we do biopsies, it's not necessarily to confirm sarcoidosis. It may be that we're pretty confident that it's sarcoidosis, but there are other diseases like cancer and infections that we're worried about, and we don't want to miss that. So sometimes we biopsy patients really just to make sure it's nothing else, even if we're reasonably sure it's sarcoidosis. And Simon showed you earlier, when you biopsy, you get these very typical clusters of cells called granulomas. The big round cluster in the middle is a collection of cells that you find in the lungs or anywhere else. And often this is quite strongly suggestive of sarcoid. So why have things changed? Well, there have been two new guidelines in the last year, one from the United Kingdom and one from America. And I want to briefly go through those guidelines in terms of biopsies. And the reason this is important is that these are the first new guidelines for more than 20 years. Until the last year, the main set of guidelines were published in 1999. This was an international statement by Europe, Japan, and North America, and this was called the International Statement of Sarcoidosis. And back then, which wasn't that long ago, things were very different in terms of biopsies. And that guideline strongly suggested that a biopsy was almost always needed to diagnose sarcoidosis. And as I said, in the last year, we've radically changed the way we think about biopsies. So going back to 1999, the statement then clearly said that in order to diagnose a patient with sarcoidosis, you needed four things. And the very first thing that it suggested was histologic confirmation of disease. And histologic is histology, which is biopsy. So the guidelines suggested strongly that the first thing to do was get a biopsy of somebody's lung or heart or organ. You then needed to work out the extent of organ involvement, work out whether the disease was stable or not, and work out whether treatment would be useful. But the biopsy was first and foremost. And they talked about types of biopsies, and they said the number one way of biopsy is called a transbronchial lung biopsy. And I'll show you an image of that later. A transbronchial lung biopsy is usually done under sedation. Some of you would have had this procedure, I'm sure, or know about it. And you pass a camera through the nose of the mouth into the lungs, and under X-ray guidance, you take a little piece of lung tissue out. Now, it's a safe procedure, but like any procedure, it does have risks, and it's something you always think about carefully before we go ahead and do. The guideline also said that if you can't do transbronchial biopsies, or if you do a transbronchial biopsy and you don't get an answer, then you need to call our surgical friends. And our surgeons come along and they put the patients to sleep with a general anesthetic and do a proper big lung biopsy, usually from the outside through keyhole surgery. And again, that's a relatively safe procedure, but it's not without risk. And our surgeons here in Papworth and in many other hospitals do this, but it's more of an intense procedure. And interestingly, you'll see that it said that some patients may refuse a biopsy. Now, we don't really use words like refuse anymore. We're much more patient-centric, as you can see if you read the guidelines, which is great. But back then, they very clearly said biopsy, biopsy, biopsy. And if you're not sure, do a biopsy. So what's changed? Well, in the last year, as I explained, two statements or guidelines have come out written by various experts, doctors, nurses, and patient groups. The British Thoracic Society statement came out a few months ago, and Sarcoidosis UK were part of that. And the British Thoracic Society document looked at lung sarcoidosis in totality, from diagnosis, including biopsy, to scans, to treatment, to follow-up of patients. Around the same time, or actually a few months before, the American Thoracic Society sent out their own guidelines. Now, these guidelines were not about lung sarcoidosis in general, but about diagnosis and detection of sarcoidosis. And so they also went into quite a large amount of detail about biopsies and when to and not to. And the really fantastic thing is that although both statements are written totally independently by different groups of people, they pretty much said the same thing when it came to biopsy. So what we now say is that we should biopsy patients when the diagnosis is unclear, meaning that in some circumstances, the clinical story, the scans of the patients, the images are so clear that this is sarcoidosis and so very unlikely to be anything else that actually we don't say you should biopsy those patients. And I'll show you two examples of such patients. We also say in those situations, even if we don't biopsy patients, we still have to follow them up quite carefully. And finally, what we all say clearly now in Europe and North America is that these decisions to biopsy or not should really be made with specialist advice. we've gone away from the days of a single doctor, perhaps a lung doctor, making decisions on when to biopsy the lung. We now have regular meetings called multidisciplinary meetings, or we sit down as teams of doctors and nurses and we make decisions about things like biopsy. And it's really crucial that the patient is always part of that, because even if we really want to biopsy somebody's lung or heart or something, the patient may not want to. And it's really important that we sit down together and talk about the risks of a biopsy and the need for a biopsy. So here are two situations where we don't biopsy anymore because we're reasonably confident the diagnosis. So all of the guidelines now in the UK and in the USA say that if you have this condition, Löfgren's disease, that some of you may have had or heard about, we don't biopsy. Löfgren's is a very acute form of sarcoidosis. It tends to come quite quickly, and it usually has a triad of three things. On the left, you can see a picture of somebody's X-ray, and the big triangular thing in the middle is the heart, and next to the heart there's two big white blobby areas of lymph nodes. And when you have very classical lymph nodes like that, and a type of arthritis, usually in the ankles but can be anywhere else, and the third thing, erythema nodosum, this very typical skin reaction, often on the front of your legs, that comes on very quickly and tends to all go quickly, we're very confident that if you've done some blood tests and taken a good story from a patient, that this is sarcoidosis. Now, we don't tend to biopsy these patients, but we do tend to follow them up with scans and images and breathing tests. But here's a very clear example now where we don't biopsy patients unless there's a very specific reason. This is the second type of patient that we don't biopsy, because sometimes, as you know, sarcoidosis is very acute and people get unwell very quickly. Other times it's either an incidental finding or they've had a diagnosis of something else for many years. And when we look back at the scans, if we're confident that on CT scans you have sarcoidosis, and importantly that it's chronic and stable over many years, that makes it much less likely to be anything different, much less likely to be a cancer or a lymphoma or something else. So if we see patients as new patients, but they've had a story that sounds like sarcoidosis for many years, and they've got scans going back many years, then again, we don't tend to biopsy. And just to go through these scans on the left to show you what they are, they're all CT scans. So again, very detailed X-ray type images. And on the left, there's a red arrow and it's pointing to a little outpouching. And this is an endobronchial lesion. So when you look down the airways into somebody's lung, there's an outpouching, which is quite typical of sarcoidosis. In the middle picture, the lymph nodes are shown, and that little white fluffy bit that it's pointing to is called Ising sugar calcification. And that could be due to other things, but in the right setting, Ising sugar calcification is suggestive of sarcoidosis. And finally, the picture on the right is what we call endobronchial beading along the fissure. So the fissure is a line that separates different parts of the lungs. And if you have little beads along that, again, that's very typical for sarcoidosis. So just to summarize what I've said, and this comes out from the British Thoracic Society statement from a few months ago, in general, when we have confident imaging, so a confident picture of somebody's lungs, whether it's on a scan or an X-ray, and as a team, we're confident the story sounds like sarcoidosis, we don't tend to biopsy those patients. We do follow them up because sometimes we get it wrong, of course, and we have to be quite careful that we follow these patients up in the clinic with scans or breathing tests, but we don't tend to. However, if the features on scans are what we call atypical, so they're not highly suggestive of sarcoid, they could be sarcoid, but they could be something else, that's when we offer a biopsy and we sit down with patients and say, something along the lines of, well, we think this is probably sarcoidosis, but I'm not completely sure it is. And given the fact that there's a little bit of uncertainty and there are some other worrying things it could be, we really would want to do a biopsy. And those are the situations where we now do a biopsy. Talking about biopsy, and I'm talking again about the lungs, because most of the time we biopsy the lungs, although we do biopsy lymph nodes and skin lesions as well. There are different ways of biopsying the lungs, and some of you would have had a bronchoscopy. You may have been awake or sedated, you may have seen what's happened. In the top left, that's a picture looking down the camera, down the telescope into somebody's lungs. And you can see all the way down to the bottom where the airways go down to the edge of the lungs, but it looks very unusual to those of us who do bronchoscopies. It should be very pink and smooth, but you can see lots of outpouchings, and we call that cobblestoning. And if you biopsy that, that's quite typical for sarcoidosis, and you often find those sarcoidosis granulomas. The top right picture is something called an ultrasound biopsy. And again, in 1999, in the original types of guidelines, we didn't talk about ultrasound biopsy because it was a new thing. It's a much more common thing now. And here, if we want to biopsy the lymph nodes, so those are the lymph nodes outside of the airways, when we put the camera down into somebody's lungs, we then add on the ultrasound probe. And that allows us to see outside of the lungs into the lymph nodes. And you may be able to just see at the top of that a very sharp white line going down. And that's the needle going out to the airway into the lymph node as it's biopsied. The bottom left is just a tube to suggest that we sometimes wash out people's lungs, and some of you might have had a washing of your lung to look for sarcoidosis. It can't diagnose the disease, but it can sometimes help support the disease. And we also do washings of people's lungs when we want to look for infections in sarcoidosis. And then finally, the bottom right is the transbronchial biopsy, the one that I mentioned at the very beginning. We do those, but less commonly nowadays. But we do those by passing a very small needle through the camera and out to the end of the camera to the edge of the lung. And we take biopsies from the edge of the lung itself. And very clearly in the British Thoracic Society guidelines, if you read them, it very clearly tells you, if you're a lung doctor or a lung nurse, how to go about biopsying the lung and in which circumstances. So as I've said before, if it's a very typical situation or you have very chronic long-standing sarcoidosis, we don't biopsy. We may do bloods and breathing tests, but we don't biopsy the lungs. If it's unusual and the patient has very big lymph nodes, then we tend to do what's called an EBUS, that ultrasound biopsy type thing. If they tend to have not big lymph nodes, but lung disease, so actually the lymph nodes are okay, but the lung tissue is affected by what's probably sarcoidosis, that's when we do this thing called the TBBX, that's the transbronchial biopsy predominantly. And we also say, if you've got sarcoidosis throughout your lungs, in the lymph nodes and the lung tissue, we tend to choose the ultrasound version first. The reason being is that you have a higher diagnostic pickup rate than the transbronchial biopsies. And if you look at all the data over the last 20 years, it tends to be a safer procedure to do than the transbronchial. So just to finish up with my last couple of slides, something that's slightly different, and you'll hear Dr. Karanas talking about this later, heart sarcoidosis. We tend to get a bit twitchy about heart sarcoid because sometimes patients are well, and even though they have lung disease, we don't treat them. But if they have heart disease, it can be, not always, but it can be something more concerning. So if we have a patient and we're unsure as to whether or not they have heart sarcoidosis, we tend to have a slightly lower threshold for biopsy, because in those cases, we need a really confident diagnosis. It's very rare that we biopsy the heart. We do it in our hospital and other hospitals. The reason that's rare is that, one, it's slightly riskier than biopsying the lung. But secondly, because sarcoidosis, when it affects the heart in patchy areas, unlike biopsying the lung, it's a lot harder to work out where you're going in the heart, and you're more likely to be taking blind biopsies. And it may be that the areas that you biopsy actually don't have the typical granulomas, and you've missed it by just biopsying. So what we tend to do is, as I mentioned at the beginning, a lot of these patients with heart sarcoid also have lung sarcoid, is we tend to do a lung biopsy. And then we tend to do a special heart scan, an MRI or a PET scan that you'll hear about later. And combining them, we say we're confident you have heart sarcoidosis. I haven't talked about the skin or lymph nodes, but these are other areas as well. So in summary, things have changed over the last 20 years, and we don't just biopsy sarcoid for the sake of it. Sometimes, whether it's a very acute case of sarcoid like Löfgren's or very chronic disease, we can be reasonably confident this is sarcoidosis. And as long as we follow up patients, we don't have to biopsy them. Secondly, because the lung is the organ that's most affected, that's the organ we tend to biopsy. And there are many different ways of biopsying the lung, using ultrasounds, using X-ray type probes, but we now have very clear protocols on which type of biopsy to do in which order to get the best answer. And then finally, the heart's a special case, and if we're worried about heart sarcoidosis, we may need a little bit more confidence, and so we may biopsy the lung to be absolutely sure in instances where we wouldn't if we weren't worried about heart sarcoidosis. So thank you very much, and this is our lovely hospital in Cambridge that some of you might have come to, and I'm going to hand back to Felix and stop sharing the screen. Thank you, Felix.
Mohunthan, thank you for that excellent talk. And and to Simon too. So we're going to do some questions. We've got a bit of time, actually. I think we've got until 11:20, so there's 11 minutes. The first question is an amalgamation of two short questions, and this is going to be for Simon. And Simon's seen the question, so we can amalgamate them. Essentially, how big a part does genetics play in sarcoid? And the person who's asked this says, as a parent, I worry about it, whether my children will get it. The second question, which is very similar, overlapping, is how far is sarcoid hereditary? So Simon, if you could answer that question, please.
Thanks, Philly. This is clearly something that concerns people. We had a few questions submitted in advance about familial risk of sarcoidosis, and I see some questions in the chat this morning about the same. So it's clearly something that concerns people. The research that's been done, Felix, suggests that if you have an affected family member with sarcoidosis, a first-degree relative, so a parent or a brother or a sister, that you're probably about 4 times more likely yourself of developing sarcoidosis than somebody who doesn't have an affected relative. So that is a reasonable genetic risk. But remember, you should be reassured that sarcoidosis is a relatively uncommon disease. So if you think that the risk of sarcoidosis on average in the population might be 1 in 10,000 people per year, then if you have 4-fold increased risk, then your risk is about 1 in 2,500 per year. So 2,500 to 1 is still pretty long odds. So the familial risk does tell us something about that there's a genetic component, something about your genes, but it doesn't confer an absolute very high risk. I hope that reassures people.
Simon, thank you very much. Can I just add a little bit to that, because other people may be thinking this. In regards to not so much genetics, but ethnicity, what are the overlaps between ethnicity and genes in sarcoid? Maybe just a broad answer to cover that bit, if you could.
Yeah, that's a very good point, Felix. We know that sarcoidosis much more commonly affects Black people. So the Black population has about a 10-fold higher risk of sarcoidosis than the white population. And they tend to get different forms of sarcoidosis as well. So clearly there is risk related to genetics related to ethnicity. There is variation across the world as well.
Wonderful. Thank you very much, Simon. The next question is for Mohunthan. Mohunthan, the question is, if sarcoidosis is affecting various parts of the body, for example, the skin, the lungs, the brain, and the liver, what specialists should you see, and how would you prioritize this in the context of several organs being involved, or at least having symptoms coming from several organs? I think this is a very common question in the clinical arena, isn't it? So that's for you, Mohunthan.
That's an absolutely brilliant question, because it affects any part of the body. When you're first diagnosed, you may end up not seeing a lung team. So if you have an eye problem, you may end up seeing the ophthalmologist. A heart problem, you see the cardiologist. But at the end of the day, once you have the diagnosis, you tend to come to the respiratory team, the lung team, because most of the time when you have sarcoidosis, the lung is affected. Now, we have lots of patients in our clinics, like all of your clinics, who have lung sarcoid and actually only have minimal lung sarcoid, but maybe have very bad eye disease or very bad heart disease. So it's really important that if they're seen in, and I'm using the lung clinic because that's where they're most commonly seen, that we work with our specialist colleagues and all of the various different teams to make sure patients are getting the best care. And there are certain, and if you read the BTS statement as well, there are certain times when we worry about sarcoidosis and treat them. And often it's outside of the lung. So I mentioned the heart. Patients who have heart sarcoidosis, we worry about a bit more. And so we're always careful that they're under a cardiology team. Patients with eye sarcoidosis, we worry about. So we now tend to recommend baseline eye tests when you're first diagnosed. If you go on certain drugs that can cause eye problems, we do regular eye tests. So again, you can come into the diagnosis of sarcoidosis through many ways, but unless you have isolated organ disease, so just eye disease, let's say, nothing else, you tend to be under the lung doctors and nurses primarily.
Mohunthan, thank you very much. Simon, I'm going to come back to you. I'm going to combine a question I've just seen on the chat and one of the questions that was sent in yesterday. So the first question comes from the chat. If a person has sarcoid in, say, the lungs, and there's another member of the family with sarcoid in a different site. Clearly that's possible. Perhaps you could touch on how likely or how common that can happen. The second question is related to that. Does current research differentiate between possible causal factors and the site of sarcoidosis, please?
Thank you, Felix. Good questions. I'm pleased that Mohantan, in his talk, gave a little description of the acute form of sarcoidosis called Löfgren syndrome. I didn't know Mohantan was going to be talking about that, but it's actually quite important in terms of answering the question, because much of the genetic risk studies, particularly related to that immune memory antigen presentation bit that suggests an infective etiology, most of those studies have been done in those patients with acute Löfgren syndrome, which seems to be particularly common in Scandinavia, but does occur in this country. So I think that the infection theory is more likely for the acute Löfgren syndrome, which does often appear as a flu-like illness with a fever as well. So it's kind of like an infection. Whereas I prefer the macrophage overexcitability theory for those patients with more chronic ongoing sarcoidosis. In terms of the different parts of the body, well, the Löfgrens does tend to affect the parts that Mohantan talked about. Of course, the other difficulty with trying to compare sarcoidosis in different parts of the body is that it does depend on how hard the doctors look at the different parts of the body as to whether you find it there or not. So I think that's a difficult one to answer.
Simon, thank you very much. Mohantan, back to you. The next question is, I originally had a biopsy done by a skin specialist, and later I was sent to an infectious disease doctor. I was told that there was no way to differentiate, to tell between TB of the skin and sarcoid. This led to another biopsy and culture, and I was finally diagnosed as sarcoid and was told that there was no treatment. So I think the question is touching on similarities and differences between, and the difficulty in differentiating between two conditions that mimic one another. And if you could touch on that, please.
Sure, that's a brilliant question. I mean, these questions are really good, actually. It's a shame we haven't got all day to answer them. As Simon said in his talk, going back to his great talk, TB may be a trigger sometimes in sarcoidosis. When we look at populations, especially in Eastern Asia, so Japan and China, there are a number of different types of propionibacteria related to sarcoid, and in Scandinavia, a number of different kinds of mycobacteria, so a type of TB. One of the reasons we biopsy patients is to try and work out whether it's sarcoid or TB, because sometimes they can look very similar. And so when we do biopsies of the lung for sarcoidosis, we always send them off for culture for tuberculosis staining. Now, the problem with that is that TB bugs take a very long time to grow. So you may have to wait for some weeks before you actually grow TB. And sometimes, of course, patients have sarcoidosis and TB, so it makes it even more complicated. There are a newer set of blood tests for TB that have come out over the last few years. They don't tell you whether you've got active tuberculosis or not, but they do generally tend to be quite good to tell you whether you've got a history of tuberculosis infection. So I think the short way of answering that very long answer is that those diseases are very similar, and that's one of the reasons why we tend to do lots of biopsies. And sometimes we get it wrong, and sometimes patients have coexisting latent or dormant tuberculosis and sarcoidosis. And then you run into all sorts of difficulties about, do you treat the TB first or do you treat the sarcoid? And so this is quite a complicated area, but it's another reason as to why we do sometimes have to biopsy patients.
Thank you, Mohantan. And I guess in the clinical arena on a day-to-day basis, often, as you said, we conclude that it may not be TB. We can't rule it out. We do go for TB treatment because if that person then needs heavy immunosuppression at some time in the future, at least you've bought that insurance, that you've covered the TB part.
Yeah, that's exactly right. So we tend to be, like you said, extra cautious and sometimes give them a few months of TB treatment, thinking actually, I want to be absolutely sure there's no active TB before I start giving them steroids or even stronger drugs for their sarcoidosis. Yes. Yeah.
Thank you. There is just 1 or 2 minutes. In fact, I've just realized there's a 10-minute gap for a break. So we could probably just run over a couple of minutes. The next question, I think I'm going to put it to both of you. There are 2 questions in the chat. One touched on lymphoma. Somebody has said, I've had sarcoid and a member of the family has a lymphoma. Another person has touched on breast cancer. So I guess malignancy lymphoma and how they interject and overlap with sarcoid. Is there such a thing? So to either of you, please.
Well, there is, if I may start, there is a connection, and I didn't have time to mention that. I think people should be reassured, and I see some questions in the chat about, if I have sarcoidosis, might I develop cancer? Well, the answer to that is generally no. But people who have cancer, some people get something that looks like sarcoidosis or a sarcoid-like reaction, where the trigger there is not an infection, but actually seems to be the tumor itself. So we do see some people with lymphoma or other cancers who then develop sarcoidosis. Not that commonly, but it does happen. Mohantan, over to you.
Yes, exactly the same, Simon. So sarcoidosis is not cancer, and it's not the same thing. But we do see cases of patients, and they tend to be cancer in the chest, really, or in the abdomen, that sometimes causes sarcoidosis. So I can think of a number of cases where patients have definitely had cancer and it's all been cured, and then a couple of years later it looks as though the cancer's come back or spread, and luckily for them it turns out it's sarcoidosis. So we're pretty confident this is what we call a sarcoid reaction to the cancer, because as Simon said in his talk, we don't know the cause of sarcoidosis, but when your immune system is altered by something like cancer, it may make you more likely to develop sarcoidosis down the line.
Thank you, Mohantan. I think there probably is time for one more question. Is everyone up for it? It's the last question on the list that was sent for Mohantan, but again, open to either of you. And I think this is important because, you know, sarcoidosis is for many people, it's a lifelong condition. And this person asks a very pertinent question. How confident can I be that the diagnosis of my fibrotic pulmonary sarcoidosis is exactly that, without having a biopsy? Because they're looking at years of having this condition and treatment to go with it. So either of you, please.
I'll say briefly, then let Simon. That person sounds like they're a professor of sarcoidosis to ask such a question. You can't be confident. So at the end of the day, without a biopsy, you can only be very, very confident, but not absolutely confident. And sometimes when you have fibrosis of the lungs that looks like other diseases like IPF or idiopathic fibrosis, it may be that it was sarcoidosis all along. Now, there are images and things within CT scans that make you much more confident that it's sarcoid, but sometimes without biopsies, you don't know. And the problem is when somebody has very fibrotic and damaged lungs, they may not be suitable for a biopsy, or they may not be safe for a biopsy, or even if you biopsy them, you may just see fibrosis and not sarcoidosis. So that's a difficult thing. But with the advent of some of these newer anti-fibrosis drugs, some of them may be available for fibrotic sarcoid down the line. So in a way, if you've got very bad fibrotic sarcoid, you might have the same sort of treatment as if you have lung fibrosis in general.
I completely agree with you, Mohantan. It's one of the challenges, and clearly one of the things that we spend a lot of time doing careful detective work with, including in our multidisciplinary meetings, isn't it, to try and work things.
Absolutely, yeah.
Great. We've got 8 minutes of the 10-minute break. The last question will be from me, for the two of you. We're going to set the bar very high for this session. So all other sessions I have to hit this bar. To the both of you, is sarcoid an autoimmune condition? And we're not going to restrict ourselves to the conventional confines of autoimmunity, but is it, broadly speaking, an autoimmune condition?
I'm going to say one word, maybe, and then I'll let Simon give a proper answer.
Yeah, well, I can make the same. I mean, in my little diagram that I put up, albeit very briefly, about the possible triggers, the antigens, self-antigens, which are the causes of autoimmune disease, are in the list as well. Some have been proposed, things called vimentin and serum amyloid proteins. There is some evidence, but like all the other things, there's evidence against as well. So I think unlikely, but I can't rule it out.
All right, great answer from the both of you. Thank you very much indeed to Dr. Mohantan Thillai and to Dr. Simon Hart. Leo, I think that concludes the first session for today.
Yes, thank you very much. We'll now have a short break and we will be back at past. Thank you very much. That was fantastic.
Thank you, everyone.
Bye.
Thank you, Felix.